mute there. Let me just start again. Okay, which screen do you see?
We don't see your slides.
What about now? Oh, hold on.
Yep, we can see your slides, but not just in, not in slideshow yet. Yep, there we go, perfect.
Which one do you see?
The title, Sepsis in the Pacific.
Is it on presenter's view or?
Yes, it is now, yep.
Hold on, let me just swap that. Oh my gosh, where is this? Can you see my notes? Are you seeing my notes or are you seeing the screen, the presentation?
Just the presentation, no
Okay,
notes.
awesome.
Yeah.
I thought you were saying. Okay, thanks again for the opportunity and the invitation. Acknowledge NCC, TRC, and Beth for organizing this talk. And for those who don't know me, my name is Lamour. I'm the clinical advisor and program coordinator at the Pacific Community for the Public Health Division, and I'm based in Suva. My background is anesthesia. I'm originally from Samoa and now based in at SBC for the last 3 years. So sepsis is always has been a passionate topic to me because of the cases that stick to mind. Has a big impact on your life, and I'm sure with all your practice in the Pacific and in the respective hospitals, you would have seen sepsis because it cuts across all disciplines: obstetrics, peds, medicine, critical care, and not only ICU, but right across. And cases that stick to mind, like obstetric mothers who die from sepsis from an infected IV line, or a young child, a 2-year-old or a 1-year-old died from pneumonia. And these cases, as a result of sepsis, always has an impact on you, and you always remember because the biggest thing is it could have been prevented if it was recognized early, treated early. And so these deaths, as you would know, are the leading cause of deaths in for in hospital. So sepsis is very important. So for today's topic, hope to bring more awareness to sepsis in the Pacific and your respective hospitals. I'll be touching on the burden of sepsis, not only globally, and a little bit how the burden in the Pacific, and then we'll have some refresher on the pathophysiology, and then focus the talk on the management, which will be focus on those 3 R's, on the recognition, resuscitation, and reassessment, and early referral. And then we'll open it to the floor for Q&As and comments. So firstly, I won't touch too much on the burden. We'll try and focus on the treatment for this talk. But as you know, this is the landmark study that was published in 2020 by WHO, and on the global burden of disease. It was an assessment from 2009 to 2017, and in it also has a burden of sepsis, and that was published in 2020. And these were some of the main findings that sepsis worldwide amounts to about 50 million cases. And of those 50 million, 11 million is sepsis-related deaths. And that accounts for about 20% or 1 in 5 of all global deaths. And almost half of that occurs among children. That's about 20 million cases. And it basically comes out to about 2 out of 5 global deaths in children under 5 years of age. So it's significant impact on the children as well. And a total of all those cases of 50 million, of about 50 million. 85% of those occur in low and middle income countries, and that includes the Pacific Islands. I've also put a obstetric, how it affects the obstetric community, our pregnant mothers, and obstetric infections, including sepsis, is the third most common cause of maternal mortality, and that's about 11% of deaths. And again, mostly occurring in low middle income countries. And even if you survive sepsis, 1 in 3 will die within a year from their initial admission. So not only is it a big burden just from the death, even has a very big morbidity impact for those who do survive. This is just another summary of the stats on sepsis from this landmark study, and the incidence is about 200 per 100,000 person years. And the overall mortality for all the regions included is about 26.7%. The in-hospital mortality is estimated to be more than a third, or 42% for all the regions. But when you break it down to the Western American, and the Western Pacific region and the region of Americas, you see those numbers there. The bottom two, they're highlighted in red. The mortality in ICU in the Americas is 76%. In the Western Pacific region is about 35%. So very, very high. We managed to do a similar survey in one of the Pacific Island countries, and the mortality that was depicted in the whole hospital was about more than 62%. So you see and they say this is underreported because it all depends on the reporting and the diagnosis that they put down and is what they enter. But even with those numbers being underreported, it's a significant burden. And that's just deaths alone. It's not accounting for the health costs and the burden on the health system in each country. Sepsis is also aligned to the SDG, particularly the SDG 3, which aims to achieve universal health coverage to everyone. And one of the main focuses of WHO in addressing vulnerable groups is the maternal, neonatal, and child mortality, so which is 3.8, 3.1, and 3.2. It also addresses other areas like the communicable diseases in 3.3, NCDs in 3.4, and universal health coverage there in 3.8. So in our region, I got this from USA. This is the amount of the costs in the US just for managing sepsis, 62 billion annually per year. In New Zealand, there's significant data that it kills more people than lung, breast, and bowel cancer combined. In Australia, from the Sepsis Network, they record about 8,000 deaths per year, which is 27% or a third of patients being admitted to ICU die from sepsis. MI and severe trauma has a higher mortality than sepsis, but the reason why I put that there is sepsis doesn't get the same attention as MI and severe trauma. When someone has an MI and comes into ED and someone sees ST elevations, they alert and activate the medical team, and they treat them straight away. Everyone comes on board. If there's severe trauma, everyone comes and address the trauma. But when someone comes with diabetic foot sepsis, they get pushed on the side. And some of the things that we see in our practice, but the mortality is much higher, and it's about 8 to 15%, depending on which hospital you reference. So there's very, very little data, if none at all, for the Pacific, and this is probably a good starting point into addressing sepsis in the region. In response to sepsis, sepsis has been around for a long time. So like I had in the title of my presentation, it's a renewed interest or renewed energy to address sepsis for a very for a chronic problem. And in 2017, this was WHO's response to try and combat sepsis, because it's a global health threat in the world. And the main objective was to reduce the burden or impact due to sepsis by supporting the member countries. And there's a list of things there, like infrastructure, the lab capacity, tools, etc., guidelines and protocols to support countries to address and to reduce the incidence um, of morbidity and mortality due to sepsis. Um, Again, that was in 2017. That's 7 years ago. And then last year on World Sepsis Day, 12 September 23, they again had this Berlin Declaration. Again, the reason being is very, very few countries of the 190 plus countries that had signed the initial agreement, the World Health WHA, only about 10 had jumped on board and is trying to address sepsis. So hence the renewed Berlin Declaration in 23 to try and urgent call for action and to provide a roadmap for countries, member states to address sepsis. I've highlighted there the WFSA, which is World Federation Society of Anesthetists. They also are on board in trying to take this forward. So moving on to the talk of sepsis. So what is sepsis? I like to keep it really, really simple. It's still not very clear how it started and why it behaves the way it does, but it's basically an overwhelming response of the body to an infection. So if I were to explain it in simple terms, if you had an abscess on your leg, you will have inflammation and the infection there is localized. And if it's treated, it doesn't spread elsewhere. But when it spreads and involves the whole body, there's generalized infection. That same abscess is now causing problems in the lungs, causing problems in the kidneys or in the liver or in the brain. There's overwhelming sepsis. Then you call it sepsis. So the old definitions, they used to have SIRS, sepsis, then severe sepsis, and then septic shock. But now with the new definition, sepsis, once you call someone sepsis, that means there has to be some organ involvement or end organ damage. And if it's not treated early, it may lead to death. The subset of sepsis is septic shock, is when there is hypotension. There's refractive hypertension, meaning after adequate fluid resuscitation and the blood pressure doesn't improve, then you call it septic shock. And this group of or subset of patients have a higher mortality, which is 40% or more. With sepsis is around 20 to 26%, 25%. So who are at risk? Some have higher risk than others. So the very young, the very old, particularly neonates and elderly, pregnancy, people with any weakened immune systems, people with chronic conditions or NCDs, and those who have been recently hospitalized for any severe illness. That's just a picture of us during the COVID in Kiribati, and we were having training around CPR and sepsis. So pathophysiology, again, it's not clearly understood, but this is what they know. There's a big imbalance between the inflammatory and anti-inflammatory response of the body to an infection. So it's just excessive, and it releases all these chemical mediators, which causes damage to the organs, causes leaky capillaries and damage to healthy tissue and in-organ impairment, and hence leading to sepsis. There's some pictures that I'll be showing. It might be bit drastic, but you may have seen it. So just a warning. So that's a typical diabetic foot sepsis, ascending sepsis on a patient who had a AKA. And diabetes is also very common in the Pacific faunias. gangrene. So focusing now on the management. So this will be our take-home message. If there's anything you would remember, one is it's a big problem. Number two, early recognition is important. Early resuscitation and early referral, requiring multidisciplinary teams to manage it effectively. So recognition, knowing the risk factors, knowing what to look for. If you don't know, you won't look for it, and if you don't look for it, you won't treat it. And resuscitation, the main three things in terms of resuscitation is manage the hypoxia, give oxygen, fluid resuscitation. Usually they require a lot of that, and early antibiotics and the right antibiotics is also important. And then referral, particularly if they need source control for the infection that's causing the problem. So just a little bit in detail on recognition. So basically, it's what you do every day following your systems. And I know it's common that we use A, B, C, D, E, and finding out before. So you basically what you're looking for here in recognition is the patient's compensatory response to infection. And this will tell you where the degree or the severity of the illness is at and how much time you have. So going through your systems in the lungs, from A, first, whether there's loss of consciousness, able to maintain their airway. B, respiratory rate, SpO2. C, the capillary refills and the peripheries, whether they're pale and clammy, the blood pressure, the pulse rate, the volume. D is your GCS, BSL, and pupils, and E is urine output. And that summarizes how we assess someone looking for end organ damage as well. So you can delineate sepsis from septic shock. But if any doubt, uh, always seek help. Whenever you're thinking sepsis, it's best that you seek help early than later, because time is life in sepsis. Recognition sometimes is the hardest, but it's not the most important step of finding what the infection is from. Sometimes we never know. But if you recognize that there is sepsis, we can institute or start the management straight away. Sorry about the noise. And then we can start the treatment early. Always keep in mind, there's another group of patients that the signs may not be obvious. For example, the elderly or immunocompromised, they may not show typical signs of infection, and especially too if they're on other medications like beta blockers. Lactate, not all hospitals in the Pacific have it, but it is important. Help with the monitoring, help with the diagnosis and monitoring of their response to treatment. I've just put this slide, just an example. Some hospitals have Muse score or the early warning scores, whatever system you use. This just basically is trying to help recognize and identify someone who's in sepsis so we can activate the teams to start treatment early, basically to treat them early. The point is early recognition. And yeah, there's another test, which is a bedside test called the Quick SOFA score. It's not really validated in the Pacific, but I still like this because not all hospitals have that blood test, and this doesn't require any blood investigations. It's a bedside test, and it basically looks at those three things. And if you have out of the three, you have diagnosis of sepsis. And I put the picture of Batman there because B for blood pressure, systolic less than 100. A is for altered mental state less than GCS 15, and tachypnea respiratory rate of more than 22. Basically, this should just mean that you need to investigate, needs further investigation for organ dysfunction and escalate therapy, meaning resuscitate and source control if needed, and early referral to your response teams or critical care teams, ICU teams. SOFA score, that's just for reference of, that's the detailed from the quick SOFA. SOFA covers those 6, and it's basically looking for end organ damage. You're looking at your lungs, your liver there, and coagulation, the heart, the brain, and your kidneys. So whenever there's impairment in the blood test, then you know you have sepsis. Okay. I've put this slide up here because of the importance of the respiratory rate, and we can never overemphasize the importance of taking our vitals. And this is one vital sign that we don't do well in our hospitals, is the respiratory rate, because there's no machine for it. We have to use our watch to count it. And when they are short staffed, everyone gets 15 or 18 respiratory rate for that shift, and it changes the next shift to 20, depending on whoever's on shift. The blood pressure, heart rate, you have numbers because there's a machine to count it. But tachypnea, respiratory, is the most reliable, more specific that there's something going on and in sepsis. The next one is tachycardia. So that's just to emphasize the importance of respiratory rate. Put this there for the types of shock and of all the different signs in the peripheries. This is one way to delineate the different types of shock, is distributive shock, which happens in sepsis or anaphylaxis or neurogenic, that the peripheries are warm as opposed to the others, which is cold. Resuscitation. So now that we've recognized that we have sepsis, resuscitation is very important and needs to be instilled within 1 hour. You may have heard of the golden 1 hour in trauma. Well, there's also a golden 1 hour in sepsis, and this will improve mortality if done early and done right. So remember the 3 things: it's oxygen, fluid resuscitation, and antibiotics, and the right one given within the hour. So there's targets for oxygen, at least 90 to 96%, and you titrate it accordingly. Fluids, you give enough. People who have sepsis or have septic shock can be behind by 4 to 6 liters. They need significant amount of fluids if they've been sick for a while. And when you give your fluids, you're always reassessing with every treatment or every bolus that you give. And I put there the early goal-directed therapy that is proven to be better than liberal fluids. And what you're looking for is your MAPS of more than 65, a lactate less than 2, or if not available, you can just use the capillary feel or feeling for coldness and warmth in their peripheries, and the urine output of more than 0.5. Just bear in mind the patients who cannot tolerate too much fluid, particularly those with heart failure, to be cautious and when giving lots of fluids. Antibiotics, giving it early is just as important as giving the right one. If you don't give the right one, it's as good as not giving anything at all. So the most broad spectrum, usually give broad spectrums until we can we identify the organisms through our cultures. A few days later, then we can narrow the spectrum down, but broad and early. And then again, as you reassess. Antibiotics, said there within an hour. It's important to do blood cultures, but if it's not available or it's not at hand, shouldn't delay you from giving antibiotics. And I'll be showing you why. If you look at this graph, it shows the time antibiotics was given and how it was for every hour delay of antibiotics. If you look at the middle chart over here, from 4 to about 5 hour mark, the mortality is in the dark, the survival fractions in the dark, what you call it now, bars, and the light one shows the antibiotics that was given, and the survival goes down by every hour of delay of antibiotics. And by the time you're on the 3rd bar over here, about 12 to 24 hours, the mortality is more than 80% for every delay. So mortality is 50% in the middle here, the middle mark. But here, after 5 hours. So for every hour delay, the mortality goes up by more than 10%. So the importance of giving antibiotics early and the correct one. So the next one, fluid resuscitation. We've already talked about that, giving about 20 to 30 ml per kilo, reassess and repeat accordingly. And the fluid of choice is crystalloids, or normal saline or Hartmann's, whatever is available. Remember, because of their leaky fluids, you may have given a lot of fluids, but they're still intravascularly depleted. Probably a third of or 2/3 of that will go into the interstitium. So we're still trying to give fluids to keep it intravascularly. For those who have significant hypotension or life-threatening hypotension, you may have to start vasopressors together with your fluid resuscitation. You don't have to wait because the blood pressure is just as important as the antibiotics. For every delay for every hour delay of a low blood pressure can also increase your mortality. And I'll put there the list of goals. Again, you titrate it to your goals, MAPS, urinary output, and a lactate of less than 2. And this slide shows the importance of maintaining a good blood pressure. One on the right is the lactate level, so less than 2.5 and more than 4, which is really bad. And then on the left here is your systolic blood pressure, less than 70 and more than 90. So the highest mortality is about here 60%. If your systolic is less than 70 and your lactate is more than 4, you have a 60% mortality. It increases. And if it's less, if your systolic is more than 90 and low lactate, that's a lesser mortality. So this is almost showing similar to the antibiotic, the importance of maintaining a good MAPS to perfuse your organs early, so there's no end organ damage and reduce the mortality. And then monitoring and assessment, just like all our sick patients, we continue to monitor and reassess as they may deteriorate even after resuscitation. So ongoing monitoring, very important. You may have seen this slide, the 1 hour bundle of 5 things that you need to do within the hour. I've already touched on that, on the lactate, the fluids, and antibiotics early, and vasopressors if needed, and septic shock. And lastly, early referral. If there is infection that can be controlled, such an abscess or intra-abdominal infection from whatever, it needs to be done within 6 hours when patient is stable or adequately resuscitated. And multidisciplinary, the more people involved, the better the outcome. Here's another example of someone who had cellulitis and had septic shock. So infections can be from anywhere, from your lungs to your heart, to your brain, to your intra-abdominal organs, to even peripherally. So put there's a lot of projects or campaigns that have been done that's available and has a lot of resources, and that's available for use within your countries. And I like to take the Sepsis Kill project from New South Wales, very simple, but very effective, supported by research that reduced morbidity and mortality in Australia. Even they had campaigns where it reduced mortality by 50% by just having rapid response teams. So we may not have rapid response teams, but the point is there's early recognition, activation, multidisciplinary teams involved in the management of sepsis. And then another leading organization, Surviving Sepsis Campaign, has a lot of resources on this. So this is the Sepsis Kill campaign by NZ New South Wales, and they have a lot of resources like I've set up here, and I can share these slides with you later, just to give us an idea of how to empower our staff in recognizing and as well as managing sepsis early. And there's some pathways and checklists to help us do that. So the way forward, I've highlighted two main things there, but all of those are very important. There needs to be more awareness. There needs to be more advocacy. There needs to be leadership, strong leadership and champions. I joined a webinar early this year on the Global Alliance response to sepsis, and there needs to be commitment, and they're calling out governments. Then it needs to be commitment right from the top to lead this. And if you can advocate for it from your hospital, please note there is support here at SPC or NCC TRC to help us push that agenda. I think the two things as a good point of start is research and collection of data. If we know the burden, if we know how big the problem is within our countries, I think it's very easy for us to convince our policymakers and administrators to address this problem. Note, sepsis now, as you know, was the leading cause of COVID. For all the COVID deaths we had was because of sepsis. If you so we need data, and data will help inform how we approach it, how to strategize, and how we can convince funding to support those activities. The other thing that I just remembered now is the AMR and antimicrobial AMR, microbial resistance, and MROs, multi-resistant organisms, all related to sepsis. And that's a leading problem, not only nationally, regionally, but globally. It's a big problem. And having this data, which is something we also did with one of the Pacific countries, we collected the data, a lot of it related to the MROs, the leading cause of deaths. And lastly, capacity building. There, you need to create not only awareness, not only within the hospital, but we can use that to inform the public, because I think we need a national response to addressing these MROs and AMRs and sepsis as well. So that's about the end of my talk, and the take-home message is early recognition, know what you're looking for, and once you find it, confirm it and start resuscitation early. Remember your oxygen, fluids, and antibiotics, and then early referral, get the other teams involved to control the source of sepsis. And remember that time is life, and for every delay, it will increase our mortality. And lastly, remember it's a preventable disease, and it's best that we invest in preventive measures than to try and manage and treat, which we don't have the resources for. I like to end with that quote from Tedros, the WHO Director General, that no one should die from sepsis, and we need to collectively step up our efforts, one, to improve data on sepsis, and then detect and treat this terrible condition. That's it from me. Happy to have take comments and questions, if any. Thank you.
Thank you so much, Lamour. That was incredibly valuable. I've learned a lot in the last hour, and all of my questions that I had were answered. So I'm just going to see if anyone else has any questions for Lamour. Great opportunity to pick his brains. So yeah, please either pop it in the chat or just unmute your microphone. You must have answered all of their questions as well,
Yeah.
Lamour.
Karen, did you want to say anything from a nursing perspective? Is Karen still on the line?
Yep, she's there. She might be
That's it.
trying to unmute, or maybe she's not in a position to unmute. I think it's also.
Sorry, I was trying to unmute.
Yeah, go Karen.
And I don't actually have anything to add, but that was a good presentation. Thanks, Lamour.
Yeah.
Thank you, Karen.
I know we have a couple of ICU and emergency nurses on the call. I'm just wondering, did either of you want to share any of your, clinical experiences that you've had? Because obviously from the data that Lamour presented, it's definitely a problem that everyone's seeing. Does anyone want to comment or provide some stories maybe of changes that they've seen in the last couple of years around management of sepsis in their areas? I've put people on the spot.
Yeah, I don't know. Lucia, I know you're from ICU in Fiji, and that's where all the sepsis goes to. And yeah.
Putting her on the spot.
Yeah, but if
maybe while she thinks about it, I think something that really stood out for me, Lamour, was when you said that, I can't remember the exact number, but the amount of people that die within 1 year after surviving sepsis. And I think that that's, something that is probably a little bit of a hidden statistic. We talk a lot about sort of more acute mortality. And in my background, I'm an occupational therapist, and my angle is always looking at the rehabilitation of people after injury and illness. And I can say that working with people who have survived sepsis is incredibly challenging, because such a high rate of amputations and chronic wounds, and just the deconditioning, alongside cognitive impairment, ongoing pain. It's a really devastating disease, both from a mortality and a morbidity perspective. So I really appreciate what you've shared today. And if does anyone want to say anything? Crystalie or Lucia?
Yeah, I think it's massive. I've only done 30-minute talk on it. It's trying to summarize it in a nutshell, but there's so much to cover, and just the death rates that we've talked about. But there's a lot of things after, and we can see that from the long COVID, how those who had COVID, there's high mortality and a lot of problems after. Coming back in, recurrent admissions just from sepsis. Yeah, so it is a big problem.
It is, yeah. So we're going to upload this recording of this presentations for the rest of the group, and I think that there'll probably be a lot of interest. So thank you so much again, Lamour. For me, it's really nice to put a face to the name. I've heard a lot about you, so it's nice to finally know your face. And thank you for making the time today, and apologies again for the technical difficulties, but
no
we
trouble.
got there in the end.
But maybe I would just like to end with if there are countries that are interested in support for addressing sepsis in their countries, don't hesitate to reach out to myself for the clinical side of things, or to Karen, who is our nursing advisor at SBC. And we can support, if not connect you with the right people. Thank you so much for the opportunity again, and have a good afternoon.
Great. Thanks, guys. Goodbye.
Awesome.
Thank you.
See ya. Bye.